Okay, so now you're welcome to the tachycardia algorithm station or the management of tachycardia. Now, what is a tachycardia? Heart rate that is above
60 to 100.
100. Heart rate above 100. Let me see your hands.
Above 150.
1. Okay, heart rate above 120. None. Heart rate above 150. 1, 2. Wow, everybody. Does it mean 120 is not a tachycardia?
Sinus tachycardia.
It's a sinus tachy, but it's a tachycardia. It's not a tachy. Very good. So that brings us to what we mean. Tachycardias are heart rates above 100. It's a tachycardia. Basic. But now, we are not so interested in treating such patients who have a sinus tachy because there's a way we're going to treat the patient will even deteriorate. So usually we just manage the symptoms and manage the underlying cause. If it is dehydration, give fluid, ask the patient to drink. If it is due to anxiety, provide rest, comfort, or allay anxiety by reassurance. If it's as a result of pain, remove the pain, alleviate the pain. Do you understand? Is it hunger? Give the person food to eat. Okay? Is it as a result of salary delay? You know that can cause tachycardia, right? It can cause a VT, even chest pain, huh? Okay. That's a lighter mood.
Also you delayed?
Sorry?
Also your salary delayed?
No. So, that's on a lighter mood
You
though.
are lucky.
So for the tachycardia, we have the heart rate that is above 100, but we are concerned about the tachyarrhythmias. These are the ones that gives trouble. Although a patient can have a tachyarrhythmia and still be stable, we still could have patients with a tachyarrhythmia that are unstable. So what informs our decision to determine this? The same 5 questions we asked. Does the patient have signs of shock, hypotension, ischemic chest discomfort, altered mental status, acute heart failure? These questions need to be answered by you to determine if the patient is stable or unstable. If the patient has none of these, the patient is regarded to be stable. What do you do? Observe the patient, vital signs, monitor the patient's ABCs. These are the things that kill the patient faster. Airway compromise, breathing poor or not adequate, circulation failure. The patients will not do so well.
H's and C's.
You need to consider very good the H's and T's. After that, what else do you need to do? Do a 12 lead. Is that right? You need to do a 12 lead ECG. What else do you want to consider? Now you need to consider, you can consider adenosine, especially for patients who have a narrow complex. How much adenosine is administered? 6 milligrams. How is adenosine given? You administer adenosine with a rapid flush technique. How is it done? Adenosine is naturally made for peripheral IVs, right? But proximal, peripheral. How do I mean? It's not advised to administer adenosine towards the distal aspect of the extremity. Proximal, so best to give it through the antecubital. But if you have Dr. Moda that has decided to give past a central line, to the patient, you can go ahead and administer adenosine through the central line. But this time, you have to give adenosine half of the dose. Half the dose. Adenosine has a very short half-life of less than 5 seconds. It means adenosine has to get to the heart within 3 to 5 seconds. The reason why most of the adenosines have been administered in tachyarrhythmias and they do not treat the patient or they do not terminate the arrhythmia is because it's either the adenosine is given so slow or with inadequate flush. Okay? So you need to use a 3-way stopcock to administer adenosine. Adenosine will be in one port, the normal saline will be in another port, so you give adenosine rapidly and you raise the limb. So adenosine gets to the heart quickly. And what does it do? It reduces AV nodal stimulation.
You recommend left side or right side?
Left, okay? So what does adenosine do? It reduces the AV nodal stimulation and then reduce, so that you will now identify the underlying tachyarrhythmia, what it is. Adenosine really does not terminate arrhythmias. It just reduces the AV node stimulation so that the actual reading, if it's an atrial flutter or atrial fibrillation, will present. Then you can now use probably a beta blocker or a calcium channel blocker to terminate it. Okay? So you've administered adenosine and that doesn't work. You need to consider a repeat dose of how much? 12 milligram. Adenosine, 12 milligram should be administered. You've given adenosine, it doesn't work.
Another 12.
You need to consider either a beta blocker or calcium channel blocker. If it doesn't terminate the arrhythmia, you seek expert consultation.
Adenosine, you can repeat it just one dose?
Yeah, you can give
The last recommendation, 2 doses can be repeated. 12.
2. You can give the first 6, the next is 12.
After
Okay.
that, can we give another 12?
After that, consider beta blocker. Yes, please.
This
And-
is a change from
2010 it was total 13 million.
total
Yes.
30 before.
So now you notice that we are giving adenosine here, but to this stable patient, not the unstable one, because adenosine on its own is an unstable medication. Adenosine causes instability in a patient.
And go to cardiac arrest.
Yeah, it could go to cardiac arrest. It could go to even a more the patient might deteriorate even faster. So you can see that adenosine causes chest pain, and that's why you need to talk to the patient. You need to counsel the patient that hello, Mr. John Doe, I understand that your heart is racing. I'll help you to bring it down, okay? But I'm going to give you a medication that might probably cause you some chest discomfort or pain. That's just for a few seconds, after which your heart rate is going to normalize. You need to talk to the patient. Adenosine is another funny medication that can also stop the heart. It can cause either a heart block or a severe bradycardia. So if you administer it to an unstable patient, the patient can deteriorate. So always remember, adenosine is given for stable patients. Now, what about that unstable patient that has 1, 2 or more of these? What do you want to do? You want to consider. Before that, there are 2 things you need to find out. How is the QRS complex?
Narrow or wide?
So we have narrow and we have wide. Examples of narrow complexes are, okay, so for this narrow, you can have it whether regular or irregular. If it is regular, what are the examples of regular narrow complexes? Regular narrow complex, you have SVT. What else do you have? Atrial flutter. It is regular and it is narrow. What are the examples of irregular narrow complexes? Atrial fibrillation, AFib. Now, let's do it this way. Okay. Similarly, if the patient is having a wide complex, you want to find out, is it regular or irregular? Just follow me the way I'm going, okay? If it is regular, examples of regular wide are or is, which one do you have? Ventricular tachycardia. Very good. Example of irregular wide complex is polymorphic ventricular tachycardia, what we call the torsades de points, right? Beautiful. Now, if the patient is having an SVT or atrial flutter, what do you want to do? You made mention of it the other time. So you want to cardiovert, right? That's why I like to use less of the word shock. You see, we meant shock the other time. We're talking of shock again. So here we need to cardiovert. How much? It's 50 to 100 joules of energy. Synchronized. You have to synchronize. Whatever we're doing here is synchronized, okay? Now, after giving this, if it doesn't work, what do you want to do next? You want to increase the energy to what?
200.
So you need to cardiovert again with a higher energy, 100. You started with 50, so the next you want to consider is 100 joules of energy. If this doesn't work, what do you want to consider next?
200.
You want to move next to administer amiodarone. Okay, how much amiodarone?
150 to 300.
150 milligrams of amiodarone. Over how long?
3 minutes. 10 minutes.
Over 10 to 15 minutes. Okay, so you administer amiodarone over 10 to 15 minutes. If amiodarone doesn't work, what do you want to do?
Then repeat the dose or the certain treatment.
Seek expert consultation. Okay, what about the irregular narrow complex? What do you want to do? Similarly, you want to cardiovert. How much? 100 to 200 joules of energy. If this doesn't work, the initial 100 does not work. You want to increase to cardiovert with how much? 200 joules. If cardioversion, the second dose does not work, what do you want to consider next? Amiodarone. How much? 150 milligrams. If amiodarone doesn't work, what do you want to consider next? Seek expert consultation. What about the regular wide complex unstable tachycardia? What do you want to do? Cardiovert. Cardiovert. How much?
120 to 200.
Cardiovert. How much do you want to give? Vitac. How much? 150 to 200 joules. If this doesn't work, you want to cardiovert again. How much? 200 joules. If this doesn't work, you want to give amiodarone. How much? 150 milligram. If this doesn't work, you want to seek expert consultation.
Switch off.
Sorry?
I switch off.
What about the irregular wide complex? Torsades de points, right? What do you want to do for the patient? CPR. What do you want to do next? Defibrillation, not cardioversion, please. That is why I like to use less of the word shock. Defibrillate with, you can go from 200 joules or more. What do you want to do next after this? Consider magnesium sulfate. After this, seek expert consultation. This is the management of your tachyarrhythmias. Now, I want you to appreciate something with this. You notice that I was not so concerned about whether it is a narrow complex or a wide complex. Whether it is a narrow complex, regular or irregular, I am not interested. Whether it is a regular wide complex, I am not interested. I will cardiovert. If it doesn't work, I will cardiovert. If it doesn't work, I will consider amiodarone. If it doesn't work, I will surely seek expert consultation and possibly would use some other avenues to manage that. The only different pathway is the polymorphic ventricular tachycardia, which is irregular wide complex, what we call the torsades de pointes. It is mostly seen in pre-eclamptic women where they come in making the agonal gasp. Now, these patients might or might not have a pulse. If they have a pulse, whether they have a pulse or not, please start CPR, because the patient that you see that has a pulse with a TDP, in the next few seconds the patient is losing it. So you need to start the CPR. First, tilt the abdomen, do the lateral tilt of the abdomen, right? And then start chest compression. Order your colleague to immediately prepare the defibrillation for shock. After you have delivered the defibrillation shock, asynchronous, you will not have to synchronize. Then you consider giving magnesium sulfate and then seek expert consultation. These patients, after defibrillating, most of them usually terminates the arrhythmia after you have given magnesium sulfate.
And that's on 2 grams.
Usually comes between 1 to 2 grams. So you can give 1.5 to 2 gram. Okay, that's the recommendation. Okay, so you can give 2 grams of magnesium sulfate and then you seek expert consultation. Is it clear? This is for the tachycardia. So don't be so, why? She's very excited. Okay, so do not be so concerned if that patient is having a narrow complex or wide. I will teach you tomorrow how to understand ECGs, okay? Just follow this pathway, you will not get it wrong. Regular, irregular, regular, wide. Just consider the patient. Is he stable or unstable? Cardiovert, amiodarone, seek expert consultation. Thank you. So you can have photographs of it if you want to, and if you're done, we continue.